Good morning, and thank you for joining us. On behalf of International Bipolar Foundation, I would like to introduce our speaker today, Dr. William Walsh. Dr. Walsh will share with us how brain-changing imbalances occur in bipolar disorder, how these imbalances alter brain levels of key neurotransmitters, disrupt epigenetic regulation of synapse activity, and cripple the body's protection against environmental toxins. He will also discuss advanced nutrient therapies. Dr. Walsh has developed biochemical treatments for patients with behavioral disorders, ADHD, autism, depression, anxiety disorders, schizophrenia, and Alzheimer's disease that are used by doctors throughout the world, and is author of Nutrient Power. He hopes to reach as many consumers about the powerful impact of nutrients on brain processes and how identifying your own biotype and taking the right nutrients can correct biochemical imbalances and improve mental health. Welcome, Dr. Walsh, and thank you so much for being with us today.
Oh, good morning. It's my pleasure. My talk today is entitled Advanced Nutrient Therapies for Bipolar Disorder. And my first slide describes who we are. We're the Walsh Research Institute. We're a not-for-profit public charity based in Naperville, Illinois. Our expertise is in schizophrenia, depression, anxiety, bipolar disorder, ADHD, autism, behavior disorders, and most recently, Alzheimer's disease. We have an active international physician training program. We just returned from North Carolina last month where we trained 23 doctors in the U.S., and in 3 weeks I'll be in Australia training with a team, with my team that will train apparently 66 doctors have registered for that. One of our main roles is experimental research, which has been part of our activity from the very beginning. We have a lot of clinical experience. In fact, I think I have the world's biggest databases, chemical databases for several of these conditions. We've worked directly with and done lab work on more than 10,000 people diagnosed with behavior and ADHD, 3,500 schizophrenias, 3,200 people diagnosed with clinical depression, and for this group, most importantly, 1,500 cases of bipolar disorder. Now, with the bipolars, we have hundreds of thousands of blood and urine chemistry results. And when you look at this, it doesn't take a genius to look at this data and realize that there's striking chemistry differences between mental illness populations and the rest of society, and it certainly goes for bipolar. Now, what do we see in bipolar? In these hundreds of thousands of lab studies, we find that, quite interestingly, there is a limited number, just a few chemical factors, or you might call them nutrient factors or biochemical factors, that dominate with respect to the imbalances that we see in bipolar. These are overmethylation, undermethylation, and I'll say a bit more about those two. Zinc deficiency. You see a lot of copper overload in bipolar. Folate deficiency or folate overload. Folate and methyl are two factors that are extraordinarily important in activity at serotonin, dopamine, norepinephrine receptors. Pyrrole disorder, which is a inborn genetic disorder that results in extremely low B6 and zinc levels. And then heavy metal overload. There are many people with bipolar disorder who seem to be especially sensitive to heavy metals. They don't have the antioxidant capability to be able to cope with things like mercury and lead. And then there are those who have fatty acid abnormalities, usually in either omega-3 or omega-6. So what have we seen with bipolar? We find that looking at our data, again, 250,000 assays of blood and urine, it clearly shows that bipolar candidates fit into four major biochemical classifications. Now, what's interesting is that if you look at the medical history information we have, each one of these biotypes, each one of these four types is associated with distinctive symptoms and traits. The people have quite different symptoms and traits, and they fit into these biotypes in terms of their behaviors and symptoms. So it appears clear to us that bipolar disorder is an umbrella term used for different mental disorders, and we believe each one of these requires a different treatment approach. Now, we've done a similar study of depression. Now, this is information that I'm going to be presenting at the annual American Psychiatric Association meeting in New York City this May. And we have an even larger database of chemistry information for depression, and what we find is that it fits into 5 biotypes. And I'm not going to go through this in detail because our subject today is bipolar, but just want to mention that the blue quadrant on the upper left, section on the upper left of 38%, those are the people who are have undermethylation as their number one chemical imbalance related to depression. And these are the people who have very low serotonin activity, and they're the ones who tend to do best if they take an SSRI antidepressant. But there are other types, completely different forms of depression that require completely different treatments. So if anyone is interested in that, you can find a lot of information on our depression work on either our website, which is www.walshinstitute.org, or our book, Nutrient Power, that came out recently. So back to bipolar disorder, the phenotypes that we find, and we're still assembling and analyzing all this information, appears to us that the 4 phenotypes of bipolar are undermethylation, overmethylation, copper-zinc imbalances, and severe oxidative stress. The undermethylation and overmethylation have a lot to do with neurotransmission, with serotonin and dopamine neurotransmission. Copper and zinc have a lot to do with norepinephrine and dopamine, which are implicated and the subject of a lot of research for bipolar. Severe oxidative stress has been seen in most cases of bipolar, and we know it has a really deleterious effect on the NMDA receptor, which is now known to be very important also in mental health. So I get a lot of phone calls from doctors and researchers, and they often will ask me a question, well, how can vitamins, minerals, or amino acids really help a patient with a bipolar disorder, with a condition that's severe? And they say, don't you really need a powerful drug to get the job done? And in reality, nutrients can have great power if you only know what the nutrient imbalances are. And the power of nutrients is primarily in 4 areas. Number 1, nutrients are the raw materials for synthesis of neurotransmitters. It's also, nutrients are very powerful, especially methyl, folate, and a few others are especially powerful with respect to the gene expression. And this is especially important at reuptake processes at synapses, the dopamine and serotonin transport proteins known as DAT and SERT. And this new knowledge from epigenetic, the world of epigenetics and the epigenetic sciences is giving us a roadmap of how to adjust neurotransmitter activity without drugs, or maybe even in conjunction with drugs. And then antioxidant protection at NMDA and GABA receptors. So their nutrients can be very powerful, and that's why when I wrote my book recently, the name of the book is Nutrient Power, because that's the message I want people to realize. Well, with respect to synthesis, we don't start life with a lifetime supply of serotonin, dopamine, and neurotransmitters. These neurotransmitters are synthesized in the brain all day, every day. And the raw materials, the precursors for this neurotransmitter synthesis are nutrients, vitamins, minerals, and amino acids. So if a person has a genetic or an epigenetic imbalance, epigenetic meaning caused by environment, in a nutrient needed for this synthesis or regulation, you can expect the person might have serious mental problems. Now, to give you an example, this slide shows the last step in the synthesis of norepinephrine. We now know that norepinephrine activity tends to be high in most cases of bipolar, especially during the manic phase. And anyway, the last very step, all your norepinephrine comes from dopamine, and this is the final step in the synthesis of norepinephrine. It's the enzyme that enables this is dopamine beta hydroxylase, one of the most famous enzymes in biochemistry. And however, you'll notice that copper, divalent copper, the copper plus plus, it's a cofactor, and in fact, this reaction doesn't go well unless copper is available in sufficient amounts or in the right amount to bind with that enzyme. And it binds loosely with the enzyme, and they've now done animal experiments where they have starved animals of copper to see whether it would change levels of norepinephrine and dopamine. Two separate studies have shown that reducing blood levels of copper down to 25% of normal can cause more than a factor of 3 difference in the ratio between norepinephrine and dopamine. And that's a huge difference. So copper has a striking impact on norepinephrine and dopamine. Now, most human beings have normal, well-controlled levels of copper. It's homeostatically controlled. There are a couple of proteins in our body that have the job of keeping copper levels normal, regardless of what the exposure is. But not everyone has that ability. Not every person has the ability to have good regulation of copper, and that seems to be one of the major phenotypes of bipolar, is dysregulated copper. Serotonin synthesis. This is the last step in the brain and throughout the body for making serotonin. And in this case, vitamin B6 in the form of PLP, also known as P5P, is a cofactor. And if you don't have a sufficient or proper amount of B6, this doesn't go well. So if a person has, for example, a Pyrrole Disorder, which is a genetic disorder that many people have that results in a really low level of vitamin B6, you can expect them to have low serotonin levels and perhaps depression. And just another example is dopamine. In this case, again, B6 is required for this very last step in the synthesis of dopamine, which comes from L-dopa. And a final example is GABA. The synthesis of GABA is shown, and this is another one that requires B6. So if a person doesn't have the proper amount of vitamin B6, it can really alter the synthesis and the amounts of neurotransmitter available in the brain. And another factor for GABA is zinc. We also know that if you don't have sufficient zinc, if a person has zinc deficiency, they tend to have low GABA activity. Well, GABA is a calming neurotransmitter that tends to overcome or cope with excess activity of norepinephrine. And we know that has everything to do with the manic phase in bipolar. And I want to mention Pyrrole Disorder. This is a genetic disorder, but it can also be caused by severe continual oxidative stress in a person. But it results in a double deficiency of B6 and zinc. And this means reduced activity of serotonin, activity at NMDA receptors, and GABA activity. And those are nasty problems, especially if a person has symptoms of bipolar. And then it also results in severe oxidative overload. Now, supplements of B6 and zinc can normalize pyrrole levels. Very often within a month, one can correct this and normalize the levels of B6 and zinc. And we've had many, many hundreds of patients who found that when this was done for them, it eliminated their symptoms and in some cases eliminated the need for psychiatric medication, depending on what the disorder was. In bipolar, very often for people with severe bipolar disorder, if they had the good fortune of having Pyrrole Disorder as their major phenotype, if they were in that phenotype, these are the people who got better more quickly, and most of them were able to most of them reported really good improvements, but many of them required still some continuing level of medication in order to prevent a relapse. Now, this brings us to methylation. Methylation, this is a dominant factor in epigenetic processes. Epigenetics basically is the process which causes our DNA in different parts of the body to produce different chemicals. We have the same DNA in every cell in our body, but different organs, different parts of the body require a different mix of chemicals, and really it's methylation that enables that. It has a methyl throughout our lives. Methylation has a powerful impact on neurotransmitter activity at synapses. And about 70% of bipolar patients from our huge database, which I think is the biggest chemistry database for bipolar in the world, 70% exhibit a serious methylation disorder, either undermethylation or overmethylation. Now, I just want to say a little bit about methylation. Some of the people watching the webinar may know a lot about methylation, but this is the methylation cycle. There's a number of enzymes that enable this cycle to function, but really it all starts with methionine, which is the top center of the diagram, and this comes from your diet. This is a protein, and it's the source of methyl in the body. And it goes through a series of well, the first thing that happens is that it's converted to something called SAMe, and that is the methyl donor for all of these reactions in the body. And but this is so important in the body that there is a very effective and efficient cycle that recovers the methionine and keeps methionine levels normalized. And many of you have heard a lot about the MTHFR and the other enzymes. When one of those enzymes has a SNP or a mutation, that means that there may or may not be a weakening in the function of that enzyme. But overall, this chart is the sort of the engine that produces methyl. And if one has a weakness in one of those enzymes, it will tend to lower methylation. And in fact, the number one cause of undermethylation in a person is a weakness in one of these enzymes, especially MTHFR is probably the most common because that's the rate limiting factor in this entire cycle. And however, then what happens to the methyl? Once the methyl is produced by that methylation cycle, what happens to it? Well, one interesting thing is that 70% of all of our methyl goes to synthesis of creatine, 70% of it. Well, creatine synthesis only works if you have certain enzymes functioning well, and there are SNPs or mutations that can cause weakness in that. And this is the primary cause of overmethylation. Quite a few people with bipolar are overmethylated, and that's because you've got the methylation cycle producing all this methyl, but the primary use of it is weakened, and so you have a glut of SAMe, and you have excess methylation capability. And really, it's a tug of war. It's a tug of war between the enzymes to determine whether a person is over-methylated, under-methylated, or has normalcy with respect to methylation. And so you have these different enzymes pulling in different directions. There's been quite a few attempts recently and commercial activities trying to use genetic testing, which can identify SNPs or specific mutations in the methylation cycle. The problem is that these SNPs are all qualitative. And for example, if a person has a MTHFR homozygous or heterozygous SNP, you still can't tell whether or not that person is going to be undermethylated or overmethylated because it's really the net effect of the SNPs that tend to diminish methylation and those that tend toward overmethylation. And this is a complexity that that exists and is just part of biochemical facts of life. There are lab tests that can directly test for overall methylation status, and those are primarily the SAMe-SAH ratio for those of you who are students of methylation, or whole blood histamine is also a good marker for overall methylation to find out how this tug of war has gone and which direction it's pulled. Now, with respect to epigenetics and mental health, I mentioned epigenetics. We now know that this is a really important factor in mental health. many familial, that is, many mental disorders that run in families appear not to be genetic, but perhaps epigenetic. And this includes schizoaffective disorder, antisocial personality disorder, that people that have that tend to populate the prisons. They're also known as sociopaths. Paranoid schizophrenia, obsessive compulsive disorder, autism. Now there's increasing evidence that that is epigenetic in nature. And it looks like bipolar disorder, and depending on which phenotype, it seems like most people with bipolar, especially those who have a breakdown event where things in a short period of time get dramatically worse after an earlier period of relative being okay, appear to be an epigenetic event. So let's just do some of the basics of epigenetics. We've got more than 20,000 genes in every cell in your body. You have about 1 trillion cells in your body. And a gene has only got one job. Each one of these genes simply makes a protein, or has the ability to make a protein. Now, liver, skin, brain, and other tissues, you need different chemicals. You need different proteins in each one of these areas. You need some of them to be producing at a high rate, and others to be completely shut down. And so how this works is kind of a miraculous, remarkable system in early genetic development, that is early in utero development, especially in the first month of gestation. As the little fetus begins to differentiate into different tissues, there is a process called epigenetics in which genes are marked with certain parts of the gene, parts of the DNA, are methylated or not methylated, and this is called bookmarking. And if everything goes right, then you have a healthy person with the right chemical environment in every part of the body. However, environmental insults can alter these gene marks and can produce mental disorders and disease conditions. Now, I have to mention what histones are. Our DNA, if you were to take the DNA in every one of our cells, the tiny little nucleus in every cell in our body has our DNA. If you were to stretch it out and pull it apart, it would be about 6 feet long. Now, the DNA is extremely fragile, and we've known for a few decades that the DNA wraps around proteins called histones. Now, a histone is got 8 linear proteins, and it's twisted together like a ball of yarn. And the DNA wraps around it. In fact, in roughly 1.8 turns around each one of these histones. And we've known about this since the 1960s and 70s, but originally we thought it only served as support, structural support for the DNA. We later found, and it's now quite clear, that it also has a lot to do with inhibiting and promoting gene expression depending on chemical reactions that histone tails. Tails are the pieces of the histones that leave that ball, and this shows a slide shows a histone, and wrapped around it, and the dark red is the DNA that wraps around 1.8 times. Now, this is what is called chromatin. Chromatin is the combination of DNA and these histone proteins. Now, there are 2 parts of epigenetics. And first of all, you have the DNA methylation itself that I was talking about. And most of this happens before birth. And the DNA and parts of the DNA are methylated or not methylated. And most of the methylation occurs at places called CPG islands, where depending on which gene we're talking about, methylation, if you have methylation in general, tends to shut off that gene and prevent an unwanted protein from appearing in a particular tissue. Or if it's not methylated, then you will have the ability to express that protein and have that chemical in the right place. But however, you also have these histone tails. You can see these 4 balls are just sort of a cartoon showing an expanded view of four for histones with the DNA wrapped around it, in this case sort of stretched apart, and the histone tails are the parts of these proteins that stick out beyond the ball, and a lot depends on whether or not you have methyl or acetyl groups attaching to those balls, because that can cause that can really impact the rate of production. Now, basically, in most cases, we're dealing with a methyl-acetyl competition. Competition between acetyl groups and methyl groups often determines whether the genes are expressed or silenced. Acetylation tends to promote gene expression. Methylation tends to inhibit it. That's a general rule, with a few exceptions. Now, nutrient therapy can change methyl-acetyl ratios, and that can adjust neurotransmitter activity. This is something we really didn't know until quite recently. Now, the way this works is the reason why the DNA attaches gently to these histones is electrostatics. DNA is a weak acid, ribonucleic acid, and the histones are somewhat basic, so they are opposite in charge, and that's why you tend to get a gentle attachment of the DNA. Now, what happens is that if you get methylation, if methyl attaches to those histones, it changes the basic nature of the histones. It makes the histones more basic, and so it tends to increase that attraction, and it tends to jam all of the histones together. Whereas acetyl groups, if acetyl wins the war, then you tend to have the DNA uncoiling and available to make proteins. So here's an example: if methylation wins the war, all of your histones jam together. Now, you cannot make a protein unless large molecules can have access to the DNA. You've got RNA polymerase. That's a chemical that is swimming around in the nucleus of every cell in your body, looking around trying to make a protein. That's one way of thinking of it. But and there are also transcription factors, which are large molecules that are also trying to partner with the RNA polymerase. And if they encounter a gene that is opened up, where it's uncoiled and laid bare, so to speak, that's how that then promotes gene expression and making of that protein. So I want to say why this is so important in bipolar. Reuptake at synapses is a dominant factor in neurotransmitter activity. The psychiatric world has known that for a long time, and SSRIs, for example, they function as reuptake inhibitors. The reuptake actually occurs through what's known as transporter proteins. The original cell neuron, the presynaptic cell neuron where the serotonin originally comes from, once a cell fires and the serotonin is now in a synapse, there's a process in which that serotonin is returned to the original cell. And I think of it like a vacuum cleaner inhaling dust particles. And it all happens through these transporter proteins. And what SSRIs do is they can disable or weaken these proteins and keep the serotonin trapped in the cell longer, in the synapse longer. And that's what antidepressants do. That's what SSRIs do. Well, the number of transporters you have, the gene expression of these transporters, well, that's regulated by epigenetic processes. And we now know that methyl, folate, niacin, and other nutrients have a powerful epigenetic impact on gene production of transporters and a powerful impact on neurotransmitter activity. So in this case, some of the nutrients can have great power, and maybe you don't always have to have a powerful drug or a foreign molecule to do the job. So we're learning a lot. The epigenetics is still in its infancy, but we've already learned quite a bit. And here's what we already know. We know that niacin and niacinamide act as dopamine reuptake promoters. and for those of you into epigenetics, there's some peer-reviewed scientific studies show that they act as reuptake inhibitors by being deacetylase inhibitors, especially of a molecule called sirtuin. We know that SAMe and methionine act as serotonin reuptake inhibitors. So they have the same function as a antidepressant, only it happens in a different mechanism. In the case of an SSRI antidepressant, they quickly get into the brain and disable these transport passageways for reuptake, whereas SAMe, actually what it does is it slows down or diminishes the genetic expression of these transporters. So you're gradually changing the population of these transport proteins and slowly and gradually inhibiting reuptake, which is what you want to do if you've got a low serotonin depressive or bipolar patient. Anyway, folates are extremely powerful in epigenetics. They reduce synaptic activity at these receptors. They reduce it. They're actually serotonin reuptake promoters. So methyl and folate have completely different opposite actions on neurotransmission with respect to the epigenetics of it. It's not so much the amount of serotonin and dopamine that you have, which was a real focus for quite a while, but it's really the reuptake and the reuptake and the transport protein function that really dominates. Anyway, one thing we've learned is that undermethylated bipolar patients are intolerant to folic acid in most cases, even though folic acid is a really excellent methylator. And this seems to be true of all kinds of folic acid, including 5-methyl tetramethyl folate, which has become really popular. All forms of folate, because of the epigenetic mechanisms, tend to have a negative effect on undermethylated patients. Anyway, there are many nutrients that influence neurotransmitter activity and brain function, and it's not just the amount of the neurotransmitter that they're impacting, but they impact the enzymes, something we've never really had an opportunity in nutrient therapy before or in complementary medicine. One thing that's always been missing is our ability with our therapy to get our hands around how to impact enzymes, which very often are the most powerful part of mental health. So how do we do this? We have individualized nutrient therapy. It's a medical process. It needs a physician that knows what he's doing. Medical history and review of symptoms. You really need to know everything you can about this patient. And one reason this is really important is that every one of these bipolar phenotypes has completely different symptoms associated with them. For example, one group is prone to seasonal allergies. Another group is prone to chemical sensitivities, on and on. So we've now collected dozens and dozens of symptoms and traits associated with each of these biotypes. So that really helps with diagnosis. And then special blood and urine lab tests. And these cost typically, for only $300 or $400 of lab testing, we can pretty efficiently identify which biotype a patient has. And then diagnosis of chemical imbalances. And then, of course, we then have an individualized nutrient program aimed at normalizing brain chemistry. We're not just hit or miss adding large quantities of anything to a person. We want to normalize their blood levels and their brain levels if they have a serious imbalance in a nutrient or a biochemical that has a lot to do with mental wellness. Okay, so for bipolar, we've identified, as best we can, nutrient therapies for each one of these bipolar phenotypes. Now, we've done open-label studies. We don't yet have double-blind controlled studies. I have applied repeatedly for funding for double-blind controlled studies because that's the best way to decisively determine the outcomes or the efficacy of a treatment. But to this point, we have open-label studies, and 74% of our patients report treatment effectiveness and the ability to reduce or eliminate medication. And usually it's a reduction of medication, not an elimination. Our treatment works in harmony with psychiatric medications. And today, most of the patients we see diagnosed with bipolar have 3 or 4 heavy-duty psychiatric medications at the same time. And if we have success, our process is we use both treatments together. We insist the patients stay on their psychiatric medication for several months. And then if we're successful, and if the patient clearly becomes quite a bit better, or if they start to become over-sedated, meaning that the medication is beginning to overwhelm them, we have them go back to their psychiatrist and then cautiously try lower and lower levels to determine where they're at their best. And in the case of severe bipolar, usually the medication levels can be reduced to a very low level, very often eliminating whatever side effects might have been a problem. But we are not trying to eliminate medications. Our goal is for the patient to be at their very best. And so this is after several months of our treatment both together, we're trying to find the optimum medication dosage. Anyway, we certainly do need to do the double-blind studies. Otherwise, it's going to be we're going to be in the category of promising rather than proven. So our bipolar approach, we continue the psychiatric medication while starting, and then after 3 to 6 months of both treatments together, if we have had a reduction in symptoms and the patient is better in many ways, then we suggest cautious reductions in medication to determine that optimum dosage. We are now engaged in bipolar research. I've been working with a renowned psychiatry expert, Dr. Robert DeVito, and the two of us have been investigating the possible causes of mania. Mania, of course, that's the dominant symptom in bipolar, and we now know pretty much what mania is. We know what it causes, but what we don't know is why does mania occur? What's going on in the microbiology of the brain? And it now looks to us like what we have in the case of mania. And basically, when a person has a manic episode, if you were to do a brain scan, you would see that they were getting that throughout the brain, generalized throughout the brain, you have excessive brain activity. You have excessive firing of brain cells. And if you look at why does a brain cell fire, what does it cause? What does it take to have a brain cell fire and inject its neurotransmitter into a synapse? Well, it has to do with voltage. It seems to us it has more to do with physics and biophysics than chemistry itself. And what you need, every brain cell has a voltage. It's about 0.15 volts. It's about 15 millivolts. And if that voltage changes and reduces to a certain point, the cell will fire just like a gun and shoot its neurotransmitter into a synapse. So it seems pretty clear that one of the leading possibilities of bipolar is that you might have something go wrong where throughout the brain cell or the neuron voltages are diminished, and therefore it doesn't take as much to cause them to fire. Well, when you look at what causes or what is responsible for these voltages at the membranes of your brain cells, of your neurons, there's been a lot of research on mitochondria, because really it's ATP. The ATP is the chemical that enables that is the power that the energy that enables these gradients to occur, these ion gradients. It's what enables sodium to be pumped out of these brain cells and the potassium to be pumped into the brain cells, and it's those ion differences that cause these voltages. And if those voltages are not exactly what they ought to be, you can have a tendency for mania. But I think even more interesting and exciting to us recently have been the research on glial cells. We now know that glial cells, these are the fatty cells that surround the brain neurons, and there's many more glial cells than there are brain neurons. And we now are learning more and more about how glial cells regulate these voltages. And so there's a lot of research now looking at what can go wrong in this regulation of neuron voltages. So I just wanted to mention that we think this is a really exciting area of research that might, within a couple of years, answer the mystery of what causes a manic episode, because that's been a big mystery in psychiatric science and research for quite a while. I think we have time for questions. One of our major activities is practitioner training. We train medical doctors, including psychiatrists. We just completed our first training in the USA in last month in North Carolina, where we trained 23 doctors. We'll be in Australia in 3 weeks. We've now got 66 doctors recruited for that and who've registered. And we may go to Ireland and Norway later this year, and it's just one of our major activities. My organization does not do clinical services anymore. We're a not-for-profit charity. We do physician training. We do research. And I'd like to leave you with Pfeiffer's Law. For every drug that benefits a patient, there are natural substances that can produce the same effect. And this was by the great Carl Pfeiffer of Princeton, New Jersey, several years ago. And I just want to remind you that we have written a book for those of you who want to dig into some of this and the topics and what I just was discussing. The book is called Nutrient Power. Thank you very much, and I think we have time for questions.
Yes, we do, Dr. Walsh. Thank you so much for that presentation. We have a few questions. I'll start with the first, which is what blood test should we have run on our daughter to find out what she is either over or underloaded?
Over or undermethylated, I think, is what she's asking.
Okay.
First of all, you need to have a doctor who is familiar with this kind of testing. You can get some kind of an indication with it with the genetic testing that's becoming quite popular, but the best way to do it is to find a direct test to look at what is the overall methyl level, whether it's overmethylated or undermethylated. Probably the best test is a test offered by Doctors Data in Illinois for SAMI-SAH ratio. In other words, measuring the ratio of two methylation molecules. SAMI, which is that's the molecule that is sort of unstable and it readily gives its methyl, and it's the donor of methyl throughout the body. And SAH is what happens to SAMI after it loses its methyl. And SAH, we now know itself has quite a bit of impact on epigenetic processes. So that's probably the best test, but it's not available to most Americans. So the other test that we recommend is whole blood histamine. Whole blood histamine, because that histamine and methyl are inverse to each other. We have a lot of histamine in the body, and we have a lot of methyl in the body. They're both what they call ubiquitous. They're both throughout every cell in your body in fairly high concentrations. And methylation is the way that histamine is regulated. So if a person has really high histamine levels, they will tend to be undermethylated. And if they have low histamine levels, the reverse. And so it's not a perfect situation, but that together with the symptoms and traits, in my book, Nutrient Power, we give tables showing the symptoms and traits associated with overmethylation and undermethylation. For example, undermethylated people tend to be perfectionistic. They tend to have very strong will. They tend to be self-motivated. They tend to be very good at the things they care about. They tend to get hooked on things. They're more addictive. They start to smoke. They'll probably smoke 3 packs a day. Most of the people with gambling disorders are undermethylated. There's a whole set of symptoms associated with it. Some that are very, very wonderful, and some which can be a problem. And they're the people most prone to low serotonin depression, and they form one of the largest phenotypes for bipolar. And so anyway, that's probably the that we know of with respect to identifying and diagnosing methylation.
Thank you. Next question, where can I go for this type of treatment in the United States?
Well, there aren't too many places that do the kind of treatment that we're talking about, and that's why we've just started our physician training. We now have 23 doctors who were trained last month, and we're now starting the process of helping them incorporate this into their practices. My website and our book both have a list of doctors and clinics that we know to be capable in this. In the USA, probably the clinic that we refer most people to is the Mensa Medical Clinic in Warrenville, Illinois. These are doctors that I worked with and trained for several years back when the Pfeiffer Treatment Center was still operating. Pfeiffer Treatment Center is a clinic that I founded that no longer exists, but they were doctors that we worked with, and there are other doctors scattered throughout the country that use some of this kind of work, but I think they are probably at this point the most experienced. But we now have 23 doctors, many of them in the southeastern USA and other parts of the USA, who tell me that they are now starting to do this, and we're going to start listing them on our website for people to utilize as soon as they tell us they're ready.
Great, thank you.
I just want to mention one other thing. We're going to have our next training program for physicians in Oak Brook, Illinois in October of this year.
Excellent. Can improvements be made through better nutrition?
Yes, nutrition can be very important. Nutrition has a lot to do with some of the disorders that some people have, and one thing we've learned is that different phenotypes require different types of nutrition. For example, people who are undermethylated thrive on a protein diet, whereas people who are overmethylated, they're the people who thrive on. They're the ones who thrive on a. They're the ones who thrive on a vegetable-based diet. They're the ones who thrive if they go vegetarian, and so there's differences from person to person. But everybody needs high-quality nutrition, and we all know the problems with junk food, and we know the importance of quality fatty acids and how we need to have the right amount of omega-3 and not omega-6, and that this has a lot of impact on brain function also. So we need to supply our bodies and our brains with high-quality nutrition, avoid empty calories, and to the extent possible, junk food, and nutrition has a lot to do with this. One of the disappointments I had in starting this kind of work was to learn that we couldn't fix most people with nutrition alone. That if a person is born with a chemical imbalance that is pretty severe, that might be a cause of bipolar or depression or anxiety or schizophrenia, you couldn't eat enough food to get the nutrients needed to overcome those genetic or epigenetic chemical imbalances. Nutrition unfortunately, we have to use targeted amounts of supplements in order to get the job done. However, you certainly, a person with a mental illness like bipolar can be harmed by a bad diet and could be assisted somewhat by a better diet.
Thank you. Next question. How do you approach treatment in a patient who becomes severely nauseated from nutrients such as B6 and zinc? Do you know of other forms of these nutrients that won't cause gastric discomfort in a sensitive patient? Small doses with food are still problematic.
Well, we've learned a lot about this. After working with 30,000 patients, we've learned that some people are very sensitive and others are not bothered by this problem. And what we've learned, for example, is that there are some nutrients that must never be taken in the morning. We know that, for example, zinc is something most people with bipolar disorder, and I think that probably is at least 90%, are either low or quite deficient in zinc. But zinc taken in the morning can cause stomach aches and nausea. And so we insist that patients take it with their evening meal, and that usually fixes that problem. B6 has to be taken in the morning, because if you take it after 3 o'clock in the afternoon, the patient will have problems, especially with an inability to get to sleep. So we've learned a lot of ways to overcome this, and it's absolutely essential. I mean, it's very frustrating for both a family and for a doctor to identify what a person's chemical imbalance is, identify a treatment program that will probably help them, and then find out that they have difficulty tolerating the nutrients. We also know that people who have the bipolar phenotype, these are people who often skip breakfast, and some of them skip lunch too. They just have difficulty eating in the morning. They tend to be nauseated in the morning. Those people need to get a system where they don't take anything in the morning, any of our nutrients in the morning, and take them later in the day when they're able to cope with the nutrients. So there is it's quite individual, but this has been something we've been able to overcome with our patients. I would say in the first 5 or 6 years of doing clinical work, this was the #1 reason why for non-responders. But we've gotten quite good at being able to show families how to do this without having discomfort, because I don't think a person is going to be willing to take a nutrient program if it makes them feel bad. So we found ways to get past that.
Thank you. Next question. I am taking methotrexate to treat rheumatoid arthritis, and I'm prescribed folate to help avoid cytotoxic side effects. I also have a diagnosis of bipolar 2. I've learned today that folate may have an adverse effect on my bipolar 2. What should I do now?
Well, methotrexate is a popular cancer treatment, and it's basically a folate inhibitor. That's why it works. In order for a cell to divide, you need to have some folate. So the idea being, one way to stop a tumor is to take away its ability to divide and grow, or even to divide to sustain where it is. So methotrexate in this case is used for a different reason, and because methotrexate's a folate inhibitor, in order for a person to become folate deficient, that's why most doctors will prescribe some folate with supplementation with it, because folate's needed in the rest of the body. Folate needs to be normalized. You need to have a normalized, proper level of folate, and the methotrexate does have a tendency to knock it down. So this folate may or may not be harming or helping this person. Now, it also depends on which phenotype of bipolar this person has. I mentioned there were 4 phenotypes. One of them involves overmethylation as the major problem. Another one involves undermethylation as the major problem. If this person happens to be in the overmethylated biotype, the folic acid would dramatically help them, or very likely cause improvements. If they're undermethylated, it would tend to make them worse. So it's highly individual.
Great, thank you. Do GMOs and pesticides contribute to biochemical imbalances?
Well, the pesticides and other environmental toxins, one of the main things, the answer is yes. They can definitely cause problems, but especially in certain people who are especially sensitive. I mean, we're not all the same, and you could have 2 people side by side exposed to a pesticide, and one could be really harmed and the other one just sail through it without a problem. So a lot depends on their innate ability to ward these things off. But one of the major problems with pesticides and these chemical toxins is they can change the epigenetics. If a sensitive person gets exposed and has an environmental insult that's really severe, it can permanently change gene expression. It can cause the onset of a condition that will not go away, because these epigenetic changes, these methyl and acetyl marks, tend to survive cell divisions. So it's highly individualized, and I've met hundreds of people who were extraordinarily sensitive to all kinds of chemicals, and especially things like pesticides. So if you're one of those people, there's two avenues of approach. One is, of course, to avoid these things as much as possible, get them out of your environment. The other is to do whatever you can to strengthen your body's ability to cope with them, which often has a lot to do with antioxidant protection. Most people who have these great sensitivities have a weakness in their natural protectors, things like glutathione and metallothioneine and selenium, these wonderful antioxidants that protect us against these foreign invaders, so to speak.
Great, thank you. Next question. There is a precaution from Mensa to avoid calcium within 2 hours of taking zinc. Can you explain why?
Well, it's a matter of trying to make sure that you get high absorption into the bloodstream. Zinc actually is something that is quite remarkable in that it's readily absorbed by the body in most people. Most people who have normal GI tract function. In fact, from foods, from the zinc that's in the foods that we eat, I think it's quite remarkable that 38% of all the zinc that you take in with food actually makes it into your bloodstream. And we now know exactly how that happens. However, there are some people who are relative malabsorbers, especially with respect to zinc. And to some level, calcium and zinc compete to make it past the intestinal membranes and get into the portal bloodstream to be delivered to the liver. And so it probably does some good to separate the two a bit. But it's just a matter of percentage. Supplements, by the way, you get more than 38% getting in your bloodstream. It's more like 70% of what you take in. And so the difference of separating it from calcium or not might be a difference between 50 and 70% of the zinc getting into your system.
Thank you. Next question. Do the phenotypes differentiate between unipolar depression and bipolar depression?
We're not sure about that. The unipolar depression and bipolar depression, I think quite a few more of them are undermethylated. Whereas in bipolar, we get a higher percent of the overmethylated phenotypes. So there are some percentage differences, and of course the difference is mania. The difference is mania and the biochemistry and the conditions that tend to cause mania, which is still somewhat of a mystery and unclear.
Thank you. What is the relationship between high copper and overmethylation? Does one cause the other?
High copper and overmethylation is a really nasty combination, and that's almost a recipe for bipolar with psychotic features or for one form of schizophrenia. And the reason is that elevated copper, as I showed in one of those slides, tends to cause a large excess of norepinephrine to form in the brain. And so if you've got a combination of high copper, overmethylation also is a character. Overmethylation is a separate mechanism by which norepinephrine gets excessive. So the two together, if you've got high copper and you have overmethylation, then you tend to have extraordinary elevation of norepinephrine and adrenaline. And these are the people who, in schizophrenia, this phenotype are the phenotype of the people who are plagued by auditory hallucinations. In anxiety cases, this is a recipe also for anxiety disorders and panic disorders. A very high percentage of them have this combination, and it's rather easy to treat. The copper overload can usually be effectively normalized in about 60 days with nutrient therapy. The methylation takes longer. Usually it takes several months to completely resolve a methylation imbalance.
Thank you. Next question. Do you see the same nutrient imbalances / methylation issues in people with borderline personality disorder?
I've seen a lot of people diagnosed with borderline personality disorder. My psychiatrist friends tell me privately that when you see somebody with a diagnosis of borderline personality disorder, it means that the psychiatrist doesn't want to see the patient anymore. It's one of those conditions that psychiatry regards as refractory or really difficult to fix, and but having said that, we do not see anything unusual about the in terms of biochemistry. We haven't done any formal studies of the people with that diagnosis, and one of the reasons we've not done a study on borderline personality is that the diagnosis is so iffy and so questionable. We've seen many people diagnosed with borderline personality disorder who are completely different from others. I don't really see that as a sharp psychiatric diagnosis. I don't think DSM-5 has really helped in that area either.
Thank you. How long should we stop supplements to get reliable results from the SAMHSA ratio tests?
With respect to supplements, say if a person is taking supplements, whatever they are, and you want to do the blood test to sort of determine what your biochemical imbalances may or may not be, we recommend that people stay on these up until maybe 2 days before the blood work, because otherwise you'd be going through some kind of a transition, and it would be really hard to evaluate what a person's innate levels are. With respect to this ratio test, that's a test that's not done very often, and I think it's going to become a very popular test. But the problem is that it's not available at hospitals, and it's not available at commercial blood draw centers by, say, Quest or LabCorp. It has to be done. It can only be done by a clinic where they have their own phlebotomy, and it requires immediate processing after the blood sample. So most people are using whole blood histamine, and that requires a person not to be taking antihistamines like Benadryl for probably a week or two before the blood test.
Thank you. Next question. If someone was to have a diagnosis of bipolar that was caused by underlying issues such as methylation issues or other absorption issues, what would explain the times of wellness when nothing is changed in terms of diet or targeted nutrient therapy?
What would explain what? I'm sorry, I missed the end of that.
What would explain the times of wellness when nothing is changed in terms of diet or targeted nutrient therapy?
I think the person's asking, why do people go through cycles? In many disorders, including bipolar, some people mysteriously get better for a while and then have a relapse later. The question is, why can you have a period of wellness? I guess the question is, why do you have a change in the severity of an illness when there's no change in the therapy? And the answer is that there are many environmental factors that affect brain function, and many of these factors are not well known, and there are environments that people get in, or dietary situations, or exposures to maybe toxics or powerful chemicals that they may not even be aware of that can alter brain function. And so there's a reason for everything, and it's not all their biochemical imbalances. There are other factors that can really affect them. I hope that answered the question. I'm not completely clear on what the question was.
Yes, thank you. This is the last question, and this person is asking for the name and phone number of the facility in Illinois where they provide testing. And also there have been requests to see your website information. And there are many, many additional questions that we can't quite get to today, so we need to sign off. If you'd like to, Dr. Walsh, put up your screen with your website information and possibly speak of any other way that they can get in touch with you.
Well, let me go through this as fast as I can.
Okay.
Our website is walshresearchinstitute.org. The email is people wanting walshinstitute.org. Our email is info@walshinstitute.org. For the information that we've discussed is available in depth either at our website or through the book Nutrient Power, which is available either from our website or also from Amazon. Now, there was a question about the. I want to mention that 100% of the proceeds of the book go to our charity. The Illinois clinic that I mentioned is Mensa Medical, and the phone number was requested, and that is 630-256. That's right. Let me get the right number here. I had an older number. Okay, it's 630-256-8308 is the number of Mensa Medical. I'm sure there are other excellent doctors around also, but those are the ones I'm most familiar with. And as far as lab testing, there are a number of labs that can do this testing. One that we use a lot that has a portfolio of our special tests and can perform most of them for under $400 is called Direct Healthcare Access, and that's a specialty lab near Chicago. And they are their website is www.pyrolureatesting.com, and they can be found if you Google Direct Healthcare Access. Other labs we use are blood work. We mainly use LabCorp, and one reason is that their histamine test is far better than the one by Quest. So if one is going to do the blood work, I would recommend LabCorp. I think that answers most of those questions.
Yes, it does. Thank you so much for this presentation. I want to also share with everyone that this presentation was recorded, and it will be on our website, archived for viewing at any time at your convenience. And I just want to say thank you very much, Dr. Walsh, for sharing your very helpful information and expertise.
Well, thank you very much.